Sadia is doing, what Mufarriq Shah Saab is doing. I'm also doing it since pre-COVID days. There are two schools. One is a missionary school in Peshawar, and other one is a private school in Peshawar. And very surprisingly, the undetected refractive errors, according to my statistics, are 10%. And that too in classes 7th, 8th, 9th, 10th. Now, this is horrifying. In private schools where we feel that the parents can afford, they are aware, and still the undetected refractive errors are 10%. I have a camp day after tomorrow as well, so let's see what happens there.
And one more thing I would like to add, sorry, the time is short. I have prepared a project and I have submitted it. It's a ZOA project to know what is. And it's all about school screening in KPK. If, I don't know, because there are big figures like PICO and from King Edward Medical University. If we win the project, we will give it to PICO to do the execution of the project. It is 1 crore rupees project for school screening.
And another thing that I'm doing it with the help of an NGO and also at times from my own resources, personal resources, and it doesn't cost much. It doesn't cost much. So it can be done even on a smaller scale. Anyhow, to start with the topic, it's etiology and presentation. Few know me, mostly do not. So I am working in Leader Reading Hospital, the oldest teaching hospital in the province. Here you can see the old building, and here is the new building setup. It's a privilege to go there. You do not feel like if you are in LRH when you walk into the new building. I am the only pediatric ophthalmologist working there, and my workload is around 10% so far in the 8 months of this year. And we are hindered presently because in our hospital, no child can get admission without a Form B. So if the child has a Form B, the child can get admission. So we are struggling. Our statistics are slightly on the lower side, especially from 1st of August. Now, pediatric cataracts, mostly we see are congenital, a child born with it, then developmental, a child acquires it through different diseases, which may be metabolic, genetic. It can be traumatic. We at LRH, and the statistics I saw here at HMC, we're dealing with a lot of trauma, of which a lot can be prevented as well. And to some extent, uveitic cataracts as well, which are probably very few. Now, pediatric cataract, as Professor Sanaullah mentioned, is not an easy thing. I think it's as difficult as to learn golf. So, same is the classification with the pediatric cataract. You can have different types of classifications. You can have them like an isolated form or associated with either systemic or ocular diseases. You can have them as congenital or acquired. You can have them inherited or sporadic. You can have them unilateral or bilateral. You can have them partial or complete. And you can have them as stable cataracts or progressive cataracts. So you have to deal with multiple things. You have to keep in mind multiple things when you're dealing with a pediatric cataract. Coming to congenital cataracts, they can be bilateral or unilateral, as we said. The bilateral ones can be with comorbidity or without any comorbidity. And this comorbidity can be either systemic or it can be ocular. And similarly, the unilateral cataracts can be either without any ocular anomalies or may be associated with ocular anomalies. Unilateral cataracts. We do see them a lot. There may be no family history. Child may be apparently healthy. You can find only in 10% any cause. And they may be associated with ocular anomalies. Now, healthy child. In a healthy child, a pediatric cataract can be idiopathic, mostly, can be hereditary, which is usually autosomal dominant, or in a study shows that in 27% of such healthy children, there may be ocular anomalies, which may be in the form of persistent fetal vasculature, aniridia, coloboma, microphthalmos, or bophthalmos. Now comes an unhealthy, unwell child. Maybe multiple things going on. So as mentioned earlier, when you see someone with a pediatric cataract, it's not the eye you need to focus upon. You need to look upon certain things, and you may have to collaborate with either a neonatology department or a pediatric department to find out the cause. So there may be multiple. Again, idiopathic is the leading one. Among others, there can be genetic mutations, metabolic disorders, skeletal deformities, chromosomal disorders, and ocular syndromes, also infective causes. Now, this is something important. This is something very important in our society, where during pregnancy, immunization now has developed, but still has to develop further. There are lots of problems, and they come up to us with pediatric cataracts. Now, this is for the book, for the learning purpose, for all the PGs who need to appear in the exam. You need to have a plenty of knowledge to know about this particular slide. I will not go into the detail of that. It's just to mention that in the causes in the unilateral and in bilateral, idiopathic remains at the top, and then they are followed by different disorders which were just mentioned in the previous slide. Surprisingly, first cousin marriage is a big factor in our society. Going upon seeing the patients, when you ask the parents, yes, the wife is either khala ki beti, mamu ki beti, mostly, somehow it goes to the mother's side. And on the lesser extent, it's like chacha ki beti and pupho ki beti. Anyhow, sorry.
One important thing in etiology I would like to add is homocystinuria. Because whenever I refer the patient before surgery to pediatrician, he checks it for homocystinuria. And other thing is the location of the lens, whether it's subluxated superiorly, inferiorly, or where it is, because it's helpful.
So it's a very surprising factor, and this is probably in our culture, and mostly so in the KPK culture, I would say, that this first cousin marriage is there. Can I get it from?
Rahil has very interesting slides.
And another thing which we have coming across regular basis is the poverty. Somehow, poor end up having more children with pediatric cataracts. And one of the factors may be associated with the torch infections, with the immunization. That is one thing which bothers a lot. Now coming to another aspect of the pediatric cataracts, with the trauma. And here again, it's very, very, very surprising that the nature of the trauma. It's really unbelievable. Every Eid al-Fitr, Eid al-Azha, you would see plenty of children coming with toy pistol trauma. Since our early days, even till today. So it's been like in the 3 decades, we are seeing it on a regular basis. Then trauma with scissors or knife. This can be prevented by education. And here I think the role of PICO to some extent, or to maybe a major extent, can come into play. Then trauma with disposable syringe. I remember one of our very senior colleagues, Professor Harun Rashid, has a dissertation on that. Trauma with disposable syringe. Trauma with stone. So these are the things which can be avoided. Of course, sports trauma can also be avoided with protective gears. But there are certain, another thing is the chicken bite, especially in the rural areas. We come across children getting trauma with chicken bites. Traumatic cataract can be either an open injury or a closed one, can be blunt or sharp, can present early or can develop late as well. Coming to the morphology of such cataracts, when you see a pediatric cataract, it's not a simple one. It can be divided into anterior, central, and posterior. And they are the different types. In the interior, polar ones, pyramidal ones, you see lamellar, you see sutural, you see nuclear. It's the posterior polar one which gives me the most scare because may be associated with the posterior lenticonus. So there are different types. The best thing is that the pupil should be widely dilated. If the child is a bit cooperative, you can see on slit lamp and you can really know the morphology. Else, at the table, when you're operating, you would find about what is actually there.
And in traumatic, it is the rosette cataract, which generally occurs.
If it's a trivial trauma. If it's a trivial trauma. Again, the same type of cataracts with their slit lamp images. You can present as total cataract, nuclear one, anterior posterior polar one, and then you can have different types of morphologies in a pediatric cataract. So it can vary a lot. Again, you can divide them, just said, the whole lens, the central, the interior, the posterior, and the miscellaneous types. So this again is for those who are appearing for exams, for their learning purpose. There's a whole lot of detail, book-wise. Now the symptoms. Somehow, very surprisingly, it's an accidental or incidental finding. That the child was brought to you for something else and you saw a cataract there. It's very strange to happen.
Yeah, you are playing with your...
I have to leave it then.
You have to be very selective. Okay. Wider.
Right. So, and another common one is the white pupil, noticed by the parents in a significant number of patients, which can be unilateral or bilateral. And then is the squinting eye. Child is brought to you by the parents. Aankh tedi hai. I'm trying to talk in Urdu for the honorable lady. And then you find out that there's a unilateral cataract.
And just to see, I'm repeating, apart from the morphology of cataract, the location, superior subluxation, inferior, anterior, or it's central, because different syndromes are associated with that and management is different.
This accidental finding, इसमें कौन से category आपने presentation?
No, it's not. It's like accidental or incidentally you find out. Yes. It's not trauma, but you come across.
They come with
some other problem and you find out, and it's in a majority of cases that you find out.
Just wait a minute. Just for TMOs, in homocystinuria, where you expect the subluxation? Huh? Inferiorly. And in Marfan's?
काफ़ी ज़्यादा, yes. And this probably, I think it's because there is no screening going on, there are no regular checkups going on. Ideally, when a child is discharged from the gynae department or ops department, I would say, there should be at least a red reflex seen. So when this is not seen, the child is taken home, apparently the child is healthy, and unless and until the child is brought to you with some other complaint, some watering, itching going on, and you suddenly find out that there is cataract there.
Are these your statistics of LRH?
No.
No.
Well, our statistics are in progress and they would be presented hopefully in February. I lost it again probably.
Yes, sir. Also, you know, the patient is also in a pediatric children, so they can't present to you that what problem I have. So that's why it's delaying the
Mostly these
presentation.
patients are brought by parents with this leukoporia, strabismus, and the children
Afzal
never
da,
see that.
this problem in this thing is constantly goes away. Mhm. Okay. Among other symptoms, if the child does not follow object or does not follow light. Nystagmus can be one symptom with which you can see the child, or the child may have some systemic illness, was brought to the pediatrician, was referred by the pediatrician suspecting something, and you find out that there is pediatric cataract. And you can have the child with photophobia, with light. The child is squeezing the eyes constantly in bright light. And then they can also come with microphthalmia or with a large eye, ophthalmia. History is very important. In such patients, history is very important. You want to know about the age of onset. You want to know about the duration of symptoms. You want to know about either a fever occurred or rash or medication during pregnancy, and this is the important part. Then you want to know about the delayed visual milestones in such a child, any history of birth trauma, or at a later stage of life, any history of ocular trauma.
Just wait a minute. From the participants, see how much they are active. What important thing should be asked more in the history? A very important thing. Family history of cataracts. Okay? History is important. Family history is important in retinoblastoma and pediatric cataracts. Both of them. Challenge.
Then you have developmental cataracts in which the older children present. They have difficulty in viewing distant objects, their inability to read blackboard sitting in the class. They usually have tendency to bring objects close to their face, and they watch television at a very close distance. Thank you very much.